I am so excited for today's guest. I know I'm going to learn a lot today, and I'm sure you will as well. Today, I have Dr. Isabelle Amigues. She is a board certified rheumatologist based in Denver, Colorado. And not only does she see and take great care of her patients, but she shares her knowledge with all of us on her podcast, Unabridged MD. And I love her mission. Her mission is to bring hope driven by science, which I think is so powerful. And today we're going to talk about the link between obesity and inflammation and how GLP-1s can help manage both of those chronic conditions. So, Dr. Amik, thank you for being here.
And thank you so much for having me. Thank you.
Yeah, so let's just get started.
Wow.
We used to assume that adipose tissue or fat cells really were inert and they just held on to our extra energy to use in the future. But we now know that is not the case and they're highly active cells. Could you just share a little bit more about how these cells are active in our body and how they contribute to inflammation?
Yeah, absolutely. So we could go into a lot of very nitty detail, like created details that, would probably not be super clear for everyone. But basically, when you do biopsies, and you can actually do fat biopsies, so you can take it in the abdomen, you can take a fat tissue biopsy, and if you're looking at it under a microscope with the proper staining and so on, you actually can see macrophage, which are inflammatory cells. And what we have found in psoriatic arthritis, so it's a very inflammatory arthritis, but we've also seen it in rheumatoid arthritis, and we probably are seeing it in other autoimmune disorder, but that's pretty clear in those two, is that the more adipose tissue you have, the more risk of inflammatory arthritis you have. And you not only have a chance to develop more, develop rheumatoid arthritis or psoriatic arthritis, you actually also develop more uh, activity, so more severe disease if you have more adipose tissue. And so while we thought that adipose tissue was inert, we are actually now clearly showing that it is inflammatory. And so the more, I mean, it's probably like everything in our body, you have to have a balance. If you have not enough, that's not great. But if you have too much, that is also not great. And so if you have too much adipose tissue or that they are hypertrophic or too big, there are more inflammatory activity.
Thank you for explaining that.
Yeah,
And like you said, we
trying to
could
make it
go
simple.
Yes, we could go into the weeds and talk about specific inflammatory markers, but I don't think that that's as important for, day-to-day application as just the general understanding. So thank you for that. And you kind of answered my next question, just how does excess adipose tissue cause inflammatory conditions, or how might it make it more severe? Because you were saying
Yeah.
if you have excess adipose tissue, then you have more inflammatory markers, and that could lead to chronic inflammatory conditions like rheumatoid arthritis or psoriatic arthritis, and it could lead to more severe disease.
Mhm.
Um, and I'm curious what your thoughts are about using GLP-1 medications to help manage these conditions. How do they play a role?
Yeah, and we can talk about GLP-1, but there is something I wanted to just touch, just to go a little bit more in more details about this inflammation related to fat tissue. I truly believe that the way that our body heals is to create inflammation, right? So if you think about it, when we have the flu, our body creates inflammation, and because there is this inflammation, we can heal, right? The issue is if the inflammation is ongoing.
Mhm.
And when you have an inflammatory arthritis like rheumatoid arthritis or psoriatic arthritis, the issue is that your body never gets back to normal. And when you are having too much adipose tissue, the issue is that you're creating a fuel on the fire. So you already have an inflammatory condition, and then you're adding those markers that are, proteins such as NF-kappa B and so on. And I'm not going to go into this, but we have like those little proteins that are causing inflammation. And so on top of having already a predisposition for rheumatoid arthritis or psoriatic arthritis, you're adding that. And so people who may develop rheumatoid arthritis way down the line are developing it earlier. Or maybe people who would not have developed it are going to develop it, right? Because there is this ongoing inflammation that's tipping the patients down into having an inflammatory process.
Mhm.
So that's something that I wanted to share. And it's going to link into the GLP-1 agonist. So I'm a huge fan, a huge fan. I was the first rheumatologist to I actually referred my first patients to endocrinology because she had psoriatic arthritis. We couldn't get her into remission, and she had diabetes. And I was like, I think you need to be on GLP-1 agonist. I really think so. She comes back and she has lost, I think she had lost 15 pounds
Mhm.
and full remission. And while the 50 pounds, yes, she had lost some weight, but she was still obese, right? I couldn't really completely explain why she was in full remission with just that one added benefit. But now it makes sense in psoriatic arthritis in a way, right? We know that adipose tissue is pro-inflammatory, especially in psoriatic arthritis. And then what are we going to decrease with, like, what we're finding is that if we're decreasing the inflammation with GLP-1 agonists, we're decreasing NF-kappa B as well. And so we're decreasing inflammation. So I think it was about a year ago, we had already, like, there was already an article in Nature in one of the big journals of medicine that showed that, like, was already raising that point of probably GLP-1 antagonists are anti-inflammatory more so than just by their decreasing the fat tissue, right? It's not just decreasing the weight. There's clearly an anti-inflammatory component. And there are studies and they are ongoing, and we're seeing that. And in psoriatic, like in my practice, where not all my patients are needing GLP-1 agonists, we're seeing that where a patient is almost in full remission, but not just there yet. Like, and you keep trying different stuff, but they are not there yet. But they are overweight or obese. You put a GLP-1 agonist, bam, they're going into full remission.
Mhm.
That's our goal, right? Full remission. And some people are a little bit, they are a little bit afraid about those drugs, and I get it.
Mhm.
But the truth is that I think it's a balance of realizing how much chronic inflammation can cause to your body, which is not great, versus those GLP-1 agonists who have been on the market for over 10 years now, because we have clearly demonstrated that people who have renal disease or heart disease don't need hemodialysis and don't have heart failure as much as they used to be. And it first was started in diabetes, but we're seeing it now like everywhere. Those drugs have the potential of changing the face of medicine.
Mhm.
And so to me, that's extremely exciting.
Yeah, I agree. I think it's we're gonna find just continue to find so many benefits. And like you said, these medications, the first one, I believe it was Byetta, the first GLP-1 that was FDA approved all the way back in 2005. And I don't know how often it was used back then, but they've been on the market for a few decades now, and we've just continued to see positive benefits. And when they're prescribed, appropriately with good guidance from a physician, plus or minus a dietitian, then people are having great results and
Yeah,
tolerating them very well overall. At least that's what I see in my practice, and hopefully that's what you're seeing as well.
totally. Oh, absolutely. Yeah.
And I have two follow-up questions about using GLP-1s in chronic inflammatory conditions. But I also want to thank you for bringing up the fact that this truly is a spectrum of disease. That's so many, really, probably all of our chronic medical conditions really are a spectrum. And so
Mhm.
the earlier we can identify where somebody is on that spectrum and intervening there to prevent, more significant disease or even prevent the development when someone's at a high risk, they're going to have better outcomes and, live longer and fuller lives. So thank you for bringing that up. Um, The two follow-up questions I have, one was about just the anti-inflammatory effects of the GLP-1s, because I've seen in my practice and I've seen people talk about it on social media how right away when they started, they felt better. They have less joint pain or more energy or other systemic benefits prior to even losing any weight. And so I'm assuming that's those anti-inflammatory properties of the GLP-1, but I was curious if you have anything to
Yeah,
add on
that's
about.
exactly it. It's basically that we think, and this is still ongoing, and it's going to take a little bit of time to actually prove, but clearly there is an anti-inflammatory effect.
Mhm.
So I mentioned the NF-kappa B, but really what we have to realize is that like the mechanism of action is, we're still learning about how it works.
Mhm.
And yeah, most of the time we know that it decreases weight by decreasing the calorie intake. But what we are failing to recognize yet, and we're starting to learn about it, is that it has an anti-inflammatory effect directly intracellular, like at the cell level. And that is what causes our patients to have less symptoms of inflammatory arthritis. Yeah. We're still learning. I think we have to be very open-minded about that and
Mhm.
very excited about researchers that are doing this work
Mhm.
because it is there, we're doing it, and we're looking into this.
Yeah, absolutely. Yeah, we always have to have that, open mindset and growth mindset and learning more. And this is a little bit of a tangent, but just like some underlying causes that are systemic, like insulin resistance or chronic inflammation, I think we're just continuing to learn more and more how those are truly the underlying causes of many of our chronic diseases, especially like cardiovascular disease, and you mentioned kidney disease and even, liver function. I think we're going to start being able to tie that all together. And these medicines really have been, I guess, one tool that has shown to link all of those things together, which is really exciting.
It is. It is absolutely. Yeah, I think that all diseases are probably inflammatory.
Mhm.
We know that cancer is due to ongoing inflammation. We know that there is more risk of recurrence of breast cancer if you are overweight. So there's definitely a link between inflammation and overweight and obesity. And in cardiovascular disease, there's a link of cardiovascular disease with rheumatoid arthritis or psoriatic arthritis, like inflammatory arthritis, cause chronic condition of heart failure, coronary artery disease. We know that. And then suddenly you're putting GLP-1 agonists that are decreasing the inflammation. It's going to help not just the heart, but also the joint. So I fully agree with you. I'm looking at it from a very systemic perspective because that is what I do as a rheumatologist. I look at the patient in his whole. It's not just the joint, right? But yeah, it's fascinating and it's very, very exciting.
Yeah. And my second question about using GLP-1 medications in chronic inflammatory conditions, and in your practice is, do you see this as an adjunct to I guess typical treatments, or could you see a role where this could replace other treatments
Yeah,
for
what
certain
a good
conditions?
question. What a very, very, very good question. Okay, I would say right now, with the evidence that we have, it's just an adjunct, right? That said, I think that a patient that is, clearly obese and that has inflammatory arthritis, you could potentially think, okay, can I get them to full remission with just a GLP-1 agonist? My take on managing rheumatologic condition is that you don't want to fire for too long, and so my goal is to put off the fire as fast as possible. To do this, you may need both, right? You need a rheumatologic anti-rheumatologic drug, and you may need a GLP-1 agonist, and then you can see how you do. I think most patients would rather not be on a GLP-1 agonist long term, so we get them off and then we decrease the amount of immunosuppression to the least amount that they need.
Mhm.
That's the goal, right? But if you're in a healthy body weight, you have much less adipose tissue, it's less inflammatory and so on. I mean, you probably are feeling better anyway, and you probably don't feel as much rheumatoid arthritis or psoriatic arthritis symptoms. So would be interesting to see. I think this we will only know this answer, get this answer in the next 5, 10 years. I don't think we're going to know that just yet. So very exciting time to be.
Yeah, absolutely. It's such an exciting time to be in medicine, especially in these fields.
Mhm.
Well, this was all super helpful. Do you have any other thoughts that you would like to share on this topic, whether
Yeah.
it's general knowledge or your thoughts about the future?
Yeah, I do. I think because I'm French, so I really want to actually. Um, I find that a lot of patients that we offer the GLP-1 agonist have a lot of judgment about it, and they
Mhm.
feel like they haven't done, it's their fault, that they did something to themselves. No, it's not. And I think insulin resistance is, a big issue in America. I think that people are more and more willing to understand that, what we put on our plate is what create our bodies. So they are more cognizant of that. And so it's really, really hard to be healthy in a world that keeps advertising fast food. That's the number one. So no guilt about that. And the second is that um, it's not our fault. Like, for example, menopause can cause insulin resistance, right? Like, and withholding a medication to help us does not actually help us. And I think, for me, the way I see it is put the GLP-1 and a healthy lifestyle so that we can go off of the GLP-1 agonist, down the line with keeping the healthy lifestyle. But at first, you may need some help, and it doesn't mean that you've done something wrong. And for me, it's like, yeah, you wouldn't say no to chemo if you had a stage 4 cancer. So then why would you say no to advances in medicine if you know that it's gonna help? Yeah.
Yeah, I love that message. Yeah, it's not your fault. And we have these safe and effective tools that we can use, and they have been proven to be very beneficial. And so I see that too. Like people are very nervous to try the medication. But I think it's something to at least consider and talk with, your doctor and see if it could be beneficial to you.
Yeah.
And if anyone is in do you see patients all throughout Colorado or just
So yeah, I see patients all throughout Colorado via telehealth, but I have two offices, one actually free, but so two in Denver and one in Boulder. We just are starting to see our first patients this week in Boulder. So I'm super excited about that. It's not super far away. And yeah, and then we have YouTube videos where I do weekly lives to explain a little bit more rheumatology because I love it. And then, everything is under Unabridged MD, and the lives are Rheumatology 101 by Dr. Isabelle Amigues, Amigues. But Rheumatology 101 should get you there normally.
That's awesome. Well, thank you so much for taking the time here today to talk with me and then all the time you take to share your knowledge with the broader population. I think we're all better with some accurate, reliable health information. So thank you again.
Thank you so much. Thanks for having me. Take care.